go. Well, welcome everyone to this edition of the GECKO Fellows Meet medical program. GECKO is hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. And the GECKO Fellows runs every second Monday at 6 p.m., as you all are now familiar. Today's topic is, as you've seen on the flyer, it's gastroesophageal reflux disease and all its little bits of attachment. And it's the presenter for the day is Patrick Nachipo from Chris Honey Baragwanath. Please take note that the chat will be open for questions. So please post your questions in there so that at the end, we just run through them quickly. Over to you, Patrick.
Thank you so much, Dr. Fredericks. Let me just share. I hope you are able to see that.
It's all good. You can go ahead.
All right. Thank you so much. As Dr. Fredericks said, I'm Patrick Nachipo from Chris Honey Baragwanath Academic Hospital. And today we'll discuss gastroesophageal reflux disease and at the end functional heartburn. So this is my outline, a bit of an introduction, some statistics, risk factors, diagnosis, treatment, and then at the end functional heartburn. So, I mean, when you talk about reflux, gastroesophageal reflux is actually a physiologic process. And this is when gastric contents are moving retrograde to the esophagus from the stomach. And this occurs multiple times during the day. And usually this does not cause any mucosal damage or any clinical symptoms. And on its own, this is not a disease. But when we talk about gastroesophageal reflux disease, it has been defined as the reflux of stomach contents into the esophagus with the troublesome symptoms and or complications. That's according to the Montreal Consensus. And it's a spectrum of diseases that will produce symptoms of heartburn and acid reflux. In essence, this is just failure of normal anti-reflux mechanism. I mean, it's a common reason for GI onset. Most of us probably we've seen a number of patients coming to our clinics, probably all those PPI clinics. And the pool prevalence is about 13%, but bear in mind, it's very difficult to come up with a prevalence because most of the patients, most of the people that suffer from this could actually be asymptomatic. And considerable geographic variation is there with the highest incidence or prevalence in Southeast Asia and South Asia and Southeast Europe. Numbers coding as high as 25%, and lowest in Southeast Asia, Canada, and France. In USA, it's about 20%, but as for most diseases, we don't have any data for Africa. And there also saw some data on the prevalence of complications, which is also difficult to ascertain unless someone goes for probably endoscopic evaluation. But it's, from one study in Sweden, erosive esophagitis was noted in about 15% of patients, and recurrent peptic strictures were recorded about 8%. That was in the year 2000. So in terms of the risk factors, we can go about the demographic risk factors, which include gender. Of note that this is from some studies from US and Europe, this has not been shown to be a factor or a determinant, but it's known that women from South America and Middle East would have at least a 40% higher rate of symptoms as compared to men in that local location. But men we know that have higher risk of esophagitis and esophageal adenocarcinoma than women. In terms of age, advanced age is associated with complications. When you look at the race, there's similar prevalence in the USA, but in terms of the numbers, but in terms of the complications, the whites have a greater risk of erosive esophagitis, buried esophagus, and the esophageal adenocarcinoma. Environmental risk factors include obesity, which has an odds ratio of about 1.73 and has increased risk of adenocarcinoma of about 2.5 with an odds ratio of 2.5. And when we look at obesity, probably central obesity may be more important than just the general rise in the BMI. And the proposed mechanism for obesity include increased intragastric pressure, and production of cytokines by the visceral fat that will lead to modulation of the lower esophageal sphincter. And these cytokines include interleukin-6 and tumor necrosis factor alpha. And there's also, in terms of environmental risk factor, the falling prevalence of Helicobacter pylori gastritis. And it's known that gastric atrophy from Helicobacter pylori seems to be inversely related to erosive esophagitis, Barrett esophagus, and adenocarcinoma. Other associations, others with a weaker association and unpredictable include smoking, physical activities like cycling, weightlifting, or swimming. In some patients with alcohol, especially the red wine. So when you look at the pathogenesis of gastroesophageal reflux disease, it's actually an imbalance between what would cause reflux and what would prevent reflux. So the anti-reflux factors will include anti-reflux barrier, which is an anatomical barrier, esophageal acid clearance and tissue resistance. And for reflux aggressive factors will include gastric acidity, the increase in gastric volume, and reflux of duodenal contents. So when you look at the gastroesophageal junction of the lower esophageal sphincter, we involve the distal 3 to 4 centimeters of the esophagus, and the proximal portion is actually 2 centimeters above the squamocolumnar junction, the Z line, and the distal 2 centimeters is actually intra-abdominal. So if you look at this diagram, it just shows the location of it with the respiratory diaphragm within the crust of the right crust of the diaphragm, and then you have the esophageal ligaments, which are holding the diaphragm, which are holding the lower esophageal sphincter within the crust of the diaphragm in place. So this is anchored, as I said, by the esophageal ligaments, and the esophagus itself enters the stomach in an oblique angle. This actually creates a sharp angle and what is known as the angle of His, and that works as a flap valve to prevent reflux of contents from the stomach into the esophagus. There are some hormones and drugs that could actually modulate the lower esophageal sphincter. So those that will increase lower esophageal sphincter would include gastrin, motilin in terms of the hormones. And in terms of other factors at the end, you see there's baclofen, there's antacids, there's histamine, there's metoclopramide. All these would actually increase your lower esophageal sphincter pressure. And for those that will reduce the lower esophageal sphincter pressure would include chocolate in terms of food, fat, and peppermint. And then in terms of drugs, things like calcium channel blockers, the diazepam, morphine, and serotonin. So in terms of the mechanism of reflux, there are a couple of things that would actually bring about reflux. And one of them is the transient lower esophageal sphincter relaxation. As the name suggests, this is just transient relaxation of the lower esophageal sphincter. And this actually occurs independent of swallowing, and it's the most frequent mechanism, up to 80% of episodes with reflux. And this lower sphincter relaxation lasts longer than 10 seconds, and it's accompanied by crural diaphragm inhibition. And this will induce, this usually is brought about by distension of the proximal stomach once there's activation by mechanoreceptors. And then another mechanism is a swallow-induced lower esophageal sphincter relaxation, and this contributes to up to 10% of the reflux episodes. And this is associated with a defective or incomplete peristalsis, and most common associated with a presence of a hiatus hernia. And then you can have a hypotensive lower esophageal sphincter pressure, which the reflux will come on whether it's strain-induced or it's just a free reflux without any strains. So for the strain-induced one is when you have relative hypotension of the lower esophageal sphincter, and this is overcome by an increase in the intra-abdominal pressure. For maneuvers like cough or straining or bending over, those that will increase intra-abdominal pressure would actually induce some reflux. And then for the free reflux is when you have a very lower esophageal sphincter pressure. Even with no increase in intra-abdominal pressure, you could actually get a reflux. And this is common when the lower esophageal sphincter pressure is lower than 5 millimeters of mercury. And you can see this in patients with end-stage systemic sclerosis, or those patients that have undergone myotomy for chalasia. And hiatal hernia probably is the central part in all these mechanisms, contributes something to all these mechanisms. And if you look at the diagram on the this diagram, just describes or just shows the hernia, how it happens. So you have the stomach that has moved, that has been put up into the chest, moved a bit into the chest, and this would lead to proximal displacement of the lower esophageal sphincter from the core diaphragm, and this will reduce the basal lower esophageal sphincter pressures. And this will eliminate the increase in pressure during straining. So when you are straining, you're supposed to have an increase in intra-abdominal, the increase in lower esophageal sphincter pressure. But once you have a hernia, this actually goes away. And because of the hernia, you also have an increase in the frequency of transient lower esophageal sphincter relaxation during gastric distension. And what this actually does is that it creates a pocket of acid in that reflux, in that herniated portion of the stomach, and this acid reflux, this acid pocket will actually keep undiluted acid gastric contents even when we've eaten, when the lower, which actually leads to persistent low exposure to the lower pH from the acid contents into the esophagus. And this is common with a large and reducible hernias, which are more prone to have a reflux. And when you look at the hernias or the lower esophageal sphincter, there is a grading system by the American Foregut Society, which they've looked at they've looked at the hiatus itself and graded according to graded as grade 1, grade 2, grade 3, and grade 4. And probably this is more of an improvement from the Hugh classification, which actually just looks at the flap valve. But this classification is more comprehensive. It looks at the hiatoaxial length. It looks at the aperture in terms of the size, and it looks at the flap valve. And you find that in most cases of reflux, you find that patients would actually get either grade 3 or grade 4 hernia, hiatohernia, where the flat valve is actually completely absent and the aperture itself is open more than 2 centimeters. So in terms of esophageal acid clearance, you have a mechanism that would clear volume or bolus from the esophagus, and this is done by peristalsis. Usually when you are in an upright position, peristalsis can work to clear any reflux content. And this is done by either primary or secondary peristalsis, and the primary is the one that is induced when we've swallowed, and the secondary one is the one that is induced by distension of the esophagus once the staph have reflux into the esophagus. And patients that have peristaltic dysfunction actually increase that they have an increased risk of and severity of esophagitis. In an upright position, gravity helps as well to clear the acid nodes in an upright position. In terms of acid clearance, you have a buffering action of saliva and esophageal gland secretions to the extent that patients that suffer from xerostomia, so those patients Sjogren, they have a prolonged acid exposure and they may have a severe esophagitis. The submucosal glands in the esophagus release bicarbonate-rich secretions, and these would be released in response to acid exposure in the lumen. The tissue resistance is the third tier in the protection against reflux, and this can be graded into pre-epithelial, epithelial, and post-epithelial as well. So the pre-epithelial one is poorly developed. As we know, in the esophagus, we don't have a well-defined mucus layer as compared to, for example, in the stomach, where you have that mucus layer with a bicarb that will protect from the acid exposure. But in the esophagus, we don't have that. And the epithelial one is probably the one that is more developed in the esophagus. So you have up to 30 cell thick layer of non-keratinized squamous epithelium with a tight epithelium that would actually prevent the acid, the hydrogen ions, atoms to move within that epithelium. And it's able to buffer and exclude hydrogen ions through transmembrane exchanges. So these cells would have a sodium hydrogen exchangers or sodium dependent bicarbonate and chloride exchangers that would actually remove the hydrogen ions out of the cells once they gain access to the cells. And then you have post-epithelial mechanism where you have a esophageal blood supply that will remove the hydrogen and carbon dioxide, keeping the environment acid free. In terms of gastric factors, so we have gastric acid secretion, So this is acid and pepsin, which are key in producing esophagitis. And then you have the role of H. pylori, especially for those that are A virulent strains. But this will depend on the location of the infection. If you have an antro-predominant infection, then you have increased acid secretion and increased risk of reflux disease. But for those that have a corpus predominant infection, actually have a reduced acid secretion because the corpus predominant will actually lead to atrophy of the corpus, and then you don't have the parietal cells that will release the acid. So we have a reduced risk of reflux disease. And then you have the gastric reflux. So exposure bile acid is actually leads to more severe esophagitis once it's exposed to the esophagus. But as of now, we don't have any mechanism of monitoring bile acid exposure or reflux to the esophagus. And then patients that have this delayed gastric emptying, it's an important. Ideally, you think that patients with a delayed gastric emptying would have a higher risk of GORD, but actually the importance of this gastric emptying is actually controversial from a multiple of studies. So when you look at the clinical features, the classic symptoms will include heartburn, regurgitation, and esophageal chest pain. But there are also other reported symptoms which include dysphagia, the water brush or rhinophagia, hiccups, and nausea and vomiting. You could also have extraesophageal manifestation, which include the chest pain, and this is the pain that actually might mimic angina pectoris. Or you could have pulmonary manifestation, which would include asthma, aspiration pneumonia, or fibrosis, or even bronchiectasis. And then you have ENT manifestation. Probably we receive a lot of patients as well from ENT, those that have a hoarse voice, those that have a frequent nose clearing, those that have recurrent sore throat. And there's also an association with sleep disorders. So we know that nocturnal GORD leads to sleep disturbance, and association has been found between obstructive sleep apnea and nocturnal reflux disease. And being an esophageal thing, so differential diagnosis would include achalasia, eosinophilic esophagitis, so patients that have Eschenker's diverticulum, gastroparesis, gallstones, even peptic ulcer disease and angina pectoris. In terms of solid conditions, it's known that up to 80% of pregnant women will complain of heartburn during the gestation period. And this is actually worse in the first trimester. And this is all because of the effect of estrogen and progesterone reducing the lower esophageal sphincter pressures. Despite being this prevalent, the esophagitis is actually uncommon, even with severe symptoms. And of note that the symptoms tend to resolve after delivery. And patients with scleroderma, up to 90% of patients with scleroderma would have reflux disease. And patients with Zollinger-Ellison syndrome, or patients after myotomy for achalasia, or after bariatric surgery, or patients with a prolonged nasogastric intubation. So the diagnosis of gastroesophageal reflux disease is based on the Lyon Consensus 2.0, which actually came out in 2024, but the committee met in 2023. And basically, you're looking at three things. So you're looking at either cell damage, evidence of cell damage, or evidence of pathological reflux on pH monitoring or impedance. So for the evidence of cell damage, looking at esophagitis, so Lysangios grade B, C, or D, buried esophagus or peptic stricture. And then when they don't have this, then those are patients that have a non-erosive reflux disease. And then for those patients, you're looking for evidence of pathological reflux. So this is just a diagram depicting how Lyon 2 would actually approach patients. So patients that have a typical heartburn with typical symptoms with heartburn, regurgitation, and esophageal chest pain, the recommended approach to them is actually an empirical trial of PPI or any form of antisecretory therapy. And then if these patients don't improve, then you can go for endoscopy, wireless pH monitoring, or pH with impedance. For those that have atypical, for example, belching, then you don't need to go with an empirical trial of PPI. You can actually go straight to endoscopy or pH impedance on monitoring. So according to American Society of endoscopic gastroenterology, this is how they want. This is their proposed approach to patients with reflux symptoms. So if you have a patient with a reflux symptoms, the first thing is to check if they have alarm symptoms. So the alarm symptoms include dysphagia, rhinophagia, weight loss, anemia, especially iron deficiency anemia, and GI bleeding. or if they have risk factors for Barrett's esophagus. So these include a family history of Barrett's esophagus and esophageal adenocarcinoma. If they have GORD plus other risk factors include 50 years of age, so male sex, white race, smoking, and obesity. Or they have a history of other post-sleeve gastrectomy. If they have those risk factors, then those patients need to have an agent endoscopic evaluation. And for those who are assessing for objective signs of acid reflux, you're assessing for the hiatogenia and the flap valve. So if they have objective signs of acid reflux with LA grade B, C esophagitis, peptic stricture, balled esophagus, then those patients are confirmed to have GORD with the troublesome symptoms, and those patients can be treated. If they don't have any alarm features and they don't have a risk factor for balled esophagus, then you are going for medical management, lifestyle interventions, and you reassess. You give this for up to 12 weeks, and then you reassess. If they don't have any symptoms, any response to symptoms, or they have persistent symptoms, then you go ahead with endoscopic evaluation. On your endoscopic evaluation, if they don't have any objective signs, but you still suspect that the patients would have reflux disease, then you do ambulatory acid reflux monitoring. And this is, they recommend that should be done off PPI. And if that is positive, then they have troublesome and they have confirmed GORD. If the dose is negative, then you evaluate for alternative causes. So in terms of reflux monitoring, the Lyon 2.0 actually recommends a prolonged 96 hours wireless pH monitoring and be done when someone is off an anti-secretory therapy. And the ambulatory pH impedance of PPI has diagnostic value. It's also recommended when patients have excessive belching, when you suspect that the patient has a rumination syndrome, or when you're evaluating for pulmonary symptoms that could be associated with your reflux disease. Ambulatory pH impedance monitoring on PPI is valuable when you have a patient with a proven reflux disease, but they still have persistent symptoms. And this is used to diagnose patients with refractory gastroesophageal reflux disease. So when you do the pH monitoring and impedance, you have metrics and thresholds that you use. And one of them is acid exposure time. So this is basically just the total time the esophagus is exposed to pH less than 4. And you can also look at the number of reflux episodes, and you look at the symptom association. So in terms of symptom association, there are 3 things that you can look to as to establish symptom association. One of them is symptom index. So this is the percentage of symptom episodes that are associated with reflux. So if a patient, for example, has 5 episodes of their symptoms of their gastric pain or something like that, or chest pain, and how many of those are associated with reflux? So that will be your symptom index. Then the symptom sensitivity index, and this is actually more or less the opposite. The percentage of reflux episodes that actually cause symptoms. So the patient has 5 reflux episodes. How many of those actually cause symptoms? Of note is that this is not usually calculated or usually done in clinical practice. And then you have the symptom association probability. So this is just a statistical calculation of the probability that your symptom or reflux link is not just due to mere chance. And then you can do a baseline impedance for those that you are doing with impedance. So for that's the exposure time more than 6%, that's the one that is diagnostic for gastroesophageal reflux disease. If you have exposure of less than 4%, with the negative reflux symptoms association, with negative symptoms reflux symptom association, that basically excludes gastroesophageal reflux disease. For those that have acid exposure time less than 4%, but they have a positive reflux symptom association, then the diagnosis becomes reflux hypersensitivity. For those that fall in the between 4 and 6% in the gray zone, then you need more tests to either determine if you need GORD treatment or not. And other conditions might be contributing to the patient's symptoms as well, so you need to be aware of that. In terms of number of reflux episodes, a total reflux episodes less than 40 per day. This is adjunctive evidence of absence of pathological gastroesophageal reflux disease. If they are more than 80%, this is an adjunctive evidence for objective GORD. And if they have reflux episodes between 40 and 80, this is inconclusive for GORD as a standalone. You cannot use this as a standalone metric to diagnose gastroesophageal reflux disease. When you talk about symptom association probability, you're going for about 95%, you're going for more than 95%, and or a symptom index of 50%. So the first thing you're looking at the symptom association probability that should be above 95% and the symptom index of more than 50%. So for those, as I said in the previous slide, for those that have acid exposure time less than 4% with positive symptom association, they would have a reflux hypersensitivity. And those that have less than 4% acid exposure time but with poor symptom association, then those patients diagnosed as having functional heartburn. When you look at the baseline impedance, so impedance basically reflects the integrity of the esophageal mucosa. It reflects the mucosal permeability. So the basic of this is that intact epithelium has high impedance, and inflamed epithelium with dilated intracellular spaces would have lower impedance. So if you have a baseline impedance of less than 1,500 ohms, this is adjunctive evidence for gastroesophageal reflux disease. If you have a baseline impedance of more than 2,500 ohms, this is evidence against pathological GORD. So in short, the Lyon Consensus 2.0 has actually looked at the evidence as conclusive evidence, borderline or inconclusive evidence, and adjunctive supportive evidence for GORD. So for those that have unproven GORD, you've done endoscopy, wireless pH study, or 24-hour pH study with impedance of therapy. Then from endoscopy, as we said, for conclusive evidence, it's LA grades B, C, and D esophagitis, biopsy-proven Barrett's mucosa, and peptic esophageal stricture. And in terms of borderline or inconclusive evidence, for those that have LA grade A esophagitis, it's borderline or conclusive evidence. And adjunctive evidence would include those that have a hiatus hernia, those that have esophageal scoring systems on which points more towards reflux, and those on that have electronic microscopy, that are on electron microscopy of biopsy of the biopsies, which shows dilated intercellular spaces. And on pH impedance is for those that have acid exposure time. For conclusive evidence, you need to have acid exposure time more than 6% in 24-hour studies. Or if you are doing the 4-day study one with a wireless pH, wireless capsule, then you are doing for more than 2 days. For borderline inconclusive includes those that have acid exposure of less than or between 4 and 6 on 24 hours, and total reflux episodes of more than of 40 to 80. Adjunctive evidence would include reflux symptom association and total reflux episodes of more than 80, and the mean night basal impedance of less than 1,500 ohms. And of note, HRM has no role in terms of diagnosing, but could actually point you towards probably risk factors if they have hypotensive EGJ, or they have a hiatus hernia, or they have ineffective esophageal motility or absent contractility. So in short, the test that will prove you'd have prove that the patient has GORD is endoscopy and pH impedance. The tests that do not prove GORD include biopsies that shows, let's say, reflux esophagitis, or a trial of PPI. Of note, for patients that have got a trial of PPI, I think there was a study in the UK, up to 51% that did not have GORD actually had a response to a trial of PPI. So there is a high placebo effect in terms of the trial of PPI in reflux disease. And barium swallow, probably we receive a lot of referrals because of the barium swallow where reflux was observed. And this is not sensitive because, as we said, there are a lot of the transient or the reflux episodes can occur throughout the day, even if a patient doesn't have reflux disease. So if those are picked up during a barium swallow, you could actually be wrongly misled that this patient could have has a reflux disease, or responses to reflux questionnaires and manometry. So all these tests do not prove or disprove GORD. So in terms of the clinical cause for the disease, you could have a non-erosive disease, which is very common, up to 70% of the patients. And these are more likely to be female, these are more likely to be younger, and they don't have a hiatus hernia. And for the erosive disease, the patients tend to be male, older, overweight, and these patients tend to relapse once you take them off your PPI, and these patients are prone to complications. So the complications would include a hemorrhage, ulcers, and perforation. And these are the most common fatal causes for reflux disease and peptic strictures. So up to 23% of esophagitis will lead to peptic stricture. And these patients will present with a progressive dysphagia, but these patients will have intact appetite as compared to those that are developing malignancy. They would actually have little weight loss. And when you do a scope, these usually are smooth walled, they're circumferential, narrowing in the distal esophagus, and usually they're less than a centimeter, but they can be as long as 8 centimeters. And another complication would include the Barrett's esophagus. So in terms of treatments, how do we approach these patients? So the first thing is the medical management and lifestyle interventions, so for 8 to 12 weeks. And this would confirm, and then after that, we confirm resolution of his esophagitis. If the symptoms have resolved, then you go for the lowest effective dose and monitor for adverse events. If they still have persistent symptoms, then you're looking for evaluation whether the patient is adherent to their medication, whether they have any coexisting conditions like eosinophilic esophagitis or they have gastroparesis, or you would consider these patients if you want to go for endoscopic anti-reflux therapy or combined endoscopic and surgical therapy. So in terms of the lifestyle modification, would include weight loss if the patient is overweight. And we know that from population-based studies, there have been shown that linear relationship exists between a BMI and GORD symptoms. And patients that are smoking, you advocate for smoking cessation and elevation of head of bed when the patients are sleeping up to about 30% of their bout, or using 2 pillows, and avoiding meals within 3 hours of bedtime. And in terms of specific food avoidance, there's no conclusive evidence to make any recommendations according to SGE Guidelines 2025. But Schlesinger would actually recommend that if a patient has specific food that will trigger their reflux episodes, then you advise them to avoid that. But there's no any blanket kind of food advice that you need to give. You could use over-the-counter medication, and this is for infrequent heartburn symptoms that include antacids, and this would work by buffering the gastric acids in the stomach. But this would have a short period of relief and might need more frequent dosing. But they work, especially versus placebo. You have an absolute benefit of about 8% with a number needed to treat of 13. And from studies, it's been shown that gaviscon is actually better with an absolute benefit of 26% and number needed to treat of 4. But these do not heal esophagitis. They only offer symptomatic relief, and that is only in a minority of patients, up to 20%. You can also use over-the-counter histamine H2 receptor antagonists, and these are superior to placebo, but they're not as effective as PPI. And these are just graphs showing some meta-analysis from different studies that look at the effectiveness of PPI versus H2 receptor antagonists. So on the graph A is patients that are free of heartburn, and you could see that up to the numbers in brackets include just shows the number of studies that showed that kind of effect. So over 8 weeks, you find that about 80% of the patients would have will be free of their heartburn, as compared to about 50% with the H2 receptor blockers. And for patients that had esophagitis and actually healed, in terms of PPI, over 12 weeks, you'd find above 85%. And for H2 receptor antagonists, you find about 60% would have healed. And for placebo, it's only just about 30%. And then you go with the prescription medication. This will include the prokinetics, and how they work would increase the lower esophageal sphincter pressure, would increase acid clearance, and would improve gastric emptying. But these medications do not change any transient lower esophageal sphincter relaxation episodes. And they have modest benefit, especially in patients that have delayed gastric emptying. So they're very good to use in patients that have concomitant delayed gastric emptying. But their use is actually limited by side effects. And those include metoclopramide, domperidone, bethanico. But of note is that SGE did not make any mention of these medications. So there's no recommendation for SGE about on the use of these medications. There's also a role for transient lower esophageal sphincter relaxation inhibitors, and this is an attractive target, especially for GORD treatment. And the only one proven at the moment available is baclofen, which is a GABA B agonist, and it improves symptoms in GORD patients. But the problem with this is just its tolerability. So it causes drowsiness, dizziness, and nausea and vomiting. And up to 20 to 30% of the patient will stop this medication because of that. And as well, there's no mention of this from American Society of Gastroenterological Endoscopy. And the histamine 2 receptor antagonists would include desimetidine, uranidine, and famotidine. These are more effective for nocturnal than meal-stimulated acid secretion. And this actually is a suggested new indication in the area where we have PPIs. So whether patients have a nighttime breakthrough reflux symptoms while they are still on PPI, you could advocate for use of H2 receptor antagonists. And tolerance develops with long-term use for these medications. So weeks to months, a patient would develop a tolerance. The recommendation for SGE is that the panel agreed on the use of H2 receptor blockers as an adjunct as needed therapy when faster onset of action might be required. And this is to be assessed on the case-by-case basis. In terms of the PPI, probably this will be the backbone, or this is the backbone for your reflux treatment. So they inhibit mealtime and nocturnal acid secretion, and they do this better than the H2 receptor antagonists. And part of the problem is they need to be tied to meal times. So they need to be taken before the first meal of the day, up to 30 minutes to 45 minutes or to an hour. And this would lead to complete healing in up to 80% of patients over 8 weeks. And in terms of among the PPIs themselves on head-to-head, esomeprazole seems to be superior to omeprazole or lansoprazole, especially for patients with more severe grades of esophagitis, C or D. Generally, PPIs are safe class. That as a class, they are safe, but they could be associated with funding gland polyps, and there's increased risk, or there have been reports of increased risk of community-acquired pneumonia and enteric infections, including Clostridioides difficile infection. And chronic use has also been associated with poor absorption of calcium, vitamin B12, magnesium, and iron. But to what extent this actually causes symptoms is actually not very clear, apart from some studies on magnesium. Case reports have been written about patients' refractory magnesium replacement only to improve after stopping their PPIs. Patients could also develop acute interstitial nephritis, and there was a concern previously around 2009 about its role in drug-to-drug interaction, especially with clopidogrel. But this recent data proves that this is no longer the case. And then there is probably relatively new, but a bit probably 10, 15 years now with the potassium competitive acid blockers, the pickups. And this is just a table looking at the comparison between pickups and PPIs. And of note is that pickups are stable to acid, and they're not as a prodrug as in PPI. PPIs usually we take them as prodrugs. They need to be converted into active ingredient. But pickups, they don't need. They're actually taken as active drugs, and they have ionic binding to the hydrogen potassium pump. And the half-life, probably one of the good things about this half-life, it's up to 9 hours, which allows it for once a day dosing as compared to PPIs, which would be 1 to 2 hours. And the timing of administration, because of that longer half-life, you don't need to tie it to meal times. So it's independent of meal time. So you can give it in other time as compared to your PPIs. And the dosing range, the time that it takes for the maximal acid suppression, actually just 1 day. After a day of taking the pickups, you have the maximal acid suppression. For our PPIs, it takes up to 3 to 4 to 5 days for you to get that. And the examples include probably the well-known is vonoprazan, tegoprazan for the pickups. So the American Gastroenterology Association has its position or statement on the use of PPI on the pickups, and of note, what we are talking about here, gastroesophageal reflux disease on our far right, is you cannot use this. So should not generally be used as a first-line therapy for an investigated heartburn or non-erosive GERD, or first-line therapy for LA grades A, B, erosive esophagitis, but may be used for healing and maintenance in LA grade C or D, or once you have failure of the BT-PPI in patients that have confirmed GERD, and should be used basically, its approved rule at the moment is HP eradication for most patients. So when to use pickups? In eradication regimens for most patients with H. pylori, for patients with severe erosive esophagitis, C and D, and those patients with documented GERD who fail only twice daily PPI therapy, there's a role for pickups. When not to use it, you can't use it as first line for investigated heartburn symptoms or non-erosive reflux disease or milder erosive esophagitis or peptic ulcer disease. And when we think pickups might have a potential utility is for on-demand treatment for reflux-related heartburn disease symptoms and for patients with a bleeding gastroduodenal ulcer with a high-risk stigmata of hemorrhage. When we're talking about treatments, then you have the medical, which we've talked about. Then you have the endoscopic, which would include the application devices. Talk about this in the coming slides. And then you have surgery. All these are options. So in terms of anti-reflux surgery, the general principle is that surgery is still the most effective treatment for true GERD. You need to confirm, that's the most important thing. You need to confirm that the patient actually has GERD before you operate on them. And this is because any operation to the OG junction actually leads to permanent changes. And your ideal surgical candidate will be someone that had confirmed GERD and they have typical symptoms. And they should have at least some partial response to PPI. If a patient is not responding to PPI or for GERD, then probably you might reconsider the diagnosis. For patients that don't have any concomitant functional symptoms or psychological concerns, talked about the disorders of gut-brain interaction, and of course, patients that are surgically fit and are willing to go for the surgery. So contraindications to anti-reflux surgery include patients that have concomitant esophageal motility disorders, so patients with peristalsis, patients with chalasia, or patients with esophageal ineffective esophageal motility. But this has been shown as probably a relative contraindication. Or patients that have diagnostic uncertainties. So are we dealing with GERD here? Are we dealing with functional heartburn? Are we dealing with reflux hypersensitivity? If we can't answer that question, those patients are not should not undergo surgery. Or patients, of course, patients that are unable to tolerate anesthesia. So your anti-reflux surgery include your Nissen and Toothpaste procedures. Those are the fundoplication procedures. And basically, they reduce acid and acid reflux episodes by decreasing transient lower esophageal sphincter relaxation episodes. They would increase basal LES pressures and inhibit complete LES relaxation. And in more than 90% of the patients after the surgical procedure have a relief of symptoms. But of note is that Barrett esophagus progression remains unchanged for these patients. So that's why you cannot do surgical therapy for patients just because you want to prevent Barrett esophagus progression. And of note is that anti-reflux surgery, these are not necessarily superior. Nissen and Toothpaste is not necessarily superior to PPI. But the complications include dysphagia because you've tied up, you might end up with a tight sphincter, so you have dysphagia, you have gas bloating, and the fundoplication can fail, and patients will need reinterventions afterwards. And patients can actually have post-obstructive symptoms after the fundoplication. And you have this MSA, so magnetic sphincter augmentation. Basically, it's a bracelet of magnets that are encased in titanium, and you place them around the lower esophageal sphincter as put on these diagrams. And basically, 58% of the patients will have their normalize their acid exposure time within a year for this. And 90% will have their PPI use within a year. So patients with the regurgitation predominant symptoms actually very favorable for this procedure. But the complications will include dysphagia, it's the same way as the fundoplication. So you are tightening the esophageal sphincter, or you could have device erosion, or you could have device explantation. In some patients can lead to a peristalsis and can also lead to a gastroparesis. In terms of the endoscopic treatment options, include the radiofrequency energy treatment, which is called well known as straighter. So the straighter is just an Italian word for tight, so it just means tight. basically what happens in this is that you deliver radio frequency energy into the muscle layer at different levels in the lower esophageal sphincter and the cardia. The exact mechanism of action is actually not very clear, but what is known is that it thickens the lower esophageal sphincter by fibrosis and muscle hypertrophy. So this is a diagram of or a depiction of the procedure. So all these white dots, these are the areas where they will deliver the radio frequency energy. And afterwards, after some time, then you have hypertrophy of the muscle and fibrosis around it, making it a bit tighter. So from on top, in terms of its efficacy or effectiveness, up to 50% would have stopped PPI, and 36% of the patients have esophageal healing of the esophagitis. But there are minor complications, so it's actually a safer procedure. You could have some erosions, could have some mucosal lacerations, and you have sustained long-term results with the positive outcomes in up to 10 years post the procedure. You could also have a transoral incision fundoplication, so that's teeth. So it uses this ESOFIX device. Basically, what you're doing is you are tying or wrapping the gastric fundus around the lower esophageal sphincter, but that is endoscopically without the need for any external incision. Basically, what you're doing is you're creating a valve of about 4 centimeters, 300 degrees in circumference around the lower esophageal sphincter. And about 90% of the patients after this procedure would actually discontinue their PPI, and up to 1 to 2% rate of adverse events. So in terms of the diagrammatic depiction of this, on this other, so these are the clips that have been put. So there's the fundus has been wrapped around the lower esophagus, and then you have clips that are put in place. So basically, this procedure is done by 2 people. One would operate the actual scope and in retrospection, retroflexion, and the other one would actually handle the actual device. So, for example, on this, so this is the device, and they are putting clips around around the lower esophageal sphincter, and at the end, it's like they're clip that they have created another leaf or a tight wrapping around the lower esophageal sphincter. You could also have anti-reflux mucosectomy. So this is a circumferential endoscopic mucosal resection of the gastric cardia. So this actually came about because it had been observed that patients that went for example, buried esophagus excision before would actually have reduced incidences or reduced symptoms from their reflux. And this was shown that it was because the mucosal defect would heal by scarring, and that would cause narrowing of the cardia. About 2/3 of the patients would discontinue their PPI, but it has a high adverse event rate, up to about 20%. So patients would develop, some patients would develop dysphagia, others would develop a stricture. And then there is the concept of refractory GERD. And we talk about refractory GERD, we talk about patients that have persistent symptoms with objective evidence of GERD despite optimal medical treatment. And for you to call them refractory GERD, they should have had a prior objective diagnosis of GERD. So you've treated them and they still have persistent symptoms, and you repeat the test and they still have objective evidence of GERD. Then you have refractory GERD symptoms. These are patients that have persistent symptoms with prior objective evidence of GERD, but despite optimal medical treatment. So these are the patients that you haven't confirmed whether they have objective evidence of GERD at this point, despite their optimal medical treatment. And then you have refractory reflux-like symptoms. So these are the patients that have persistent symptoms of GERD on optimal medical treatment, but you didn't have any prior objective GERD diagnosis in those patients. And then you have what we mean by optimal acid suppression treatment. So they need to be on a stable PPI twice a day or a maximum pickup dose at least for 8 weeks. Those are the patients that should say they have had optimal acid suppression. So what would be the potential causes for refractory GERD? So those patients that have persistent reflux, either they have a poor PPI adherence or they have a rapid PPI metabolism, residual acid reflux, or they have a bioacid reflux, or those that have anatomical motor abnormalities of the upper GIT. So it includes patients with gastroparesis, patients that have achalasia, motility problems, IEM, absent motility, or patients that have a large hiatohenia, and that is defined as something that is larger than 2 centimeters, or patients that have undergone a POEM procedure, or patients that have other disorders of gastric gut-brain interaction. So patients with a reflux hypersensitivity, functional heartburn, or functional dyspepsia, or patients that have other mucosal disorders, for example, eosinophilic esophagitis, or other causes of esophagitis, including infectious or pill-induced. When you have these patients, then you need to, if they have incomplete response to PPI, then you need to, do they have evidence of GORD? If they have proven evidence of GORD after your upper endoscopy or pH impedance, then those patients, they still have esophagitis with a grade B, then those patients will be termed to have refractory GORD. So how do you manage these patients? So you need lifestyle measures. So still re-emphasize on lifestyle measures, so weight management, smoking, avoid eating close to bedtime or sleeping with a head of bed elevated. You need to optimize their anticipatory therapy, so they need to have their twice daily dosing of PPI. And you can consider adjunctive or topical agents, including the baclofen, which would actually work to reduce the transient lower esophageal sphincter relaxation. Or you might actually consider adding antacids. And consider diaphragmatic breathing. So adjunctive measures include cognitive or behavioral therapy or gut-directed hypnotherapy. And then you can also consider invasive GORD management. So these include the anti-reflux surgery or endoscopic procedures. So we know that the PPI is metabolized by CYP2 C19, so a part of the P450 enzyme system. And some patients would have genotypical, its availability is affected by genotypes. So there are patients that are rapid or ultra-rapid metabolizers, and this would reduce its availability. But there is a lack of robust evidence in terms of 2C19 testing. So the stance or the statement from ACG is that it's the best practice advice to suggest that you need to assess patients for CYP 2C19 genotype and tailoring their PPI therapy accordingly, especially in patients with persistent and confirmed GORD who have failed to respond to standard medical therapy. And probably among the PPIs, the one that does not use CYP 2C19 is rabeprazole. So if you have a patient that is a rapid or ultra-rapid metabolizer, then rabeprazole might be your best choice. Or you can go for a pickup. So let's finish with a functional heartburn. So these are patients that have retrosternal burning like symptom, like in GORD, but without any evidence, objective evidence of abnormal esophageal acid exposure or motility disorders or esophageal mucosal pathology. So these are the up to 40% of patients that are refractory to our PPIs would be patients that have functional heartburn. And it's important to recognize these patients because they might, we have patients that are on PPI for up to 5 years and you're unable to win them off. So there's a cost on the medication from the medication point of view. And it's nice to recognize these patients because anti-reflux surgery and other invasive modalities should be avoided at all costs. So for the diagnosis, going to the room for, they include all of these. So you have the burning retrosternal discomfort or pain, no symptom relief despite optimal anticipatory therapy, and absence of evidence of gastroesophageal reflux, eosinophilic esophagitis as the cause of the symptoms, and absence of major esophageal motor disorders. And these criteria need to be fulfilled for the last 3 months with symptom onset in the last 6 months. So how do you treat or how do you assess these patients? So this is just a summary of probably everything that we've talked about. So we are looking at patients that don't have objective evidence on endoscopy and on your PPI, on your APH impedance, they have They don't have any adjunctive evidence of GORD, so their exposure time is less than 4%. They have a negative reflex symptom association. Those are the patients that have functional heartburn. And in terms of your treatment, you are aiming to improve the symptoms, symptom resolution, and prevention of symptoms recurrence. So your treatment options, of course, the first thing is the patient needs to understand what is going on, and then lifestyle modification include improved sleep experience. Pharmacotherapy would include our immunomodulators, neuromodulators, so the TCS, the SSRIs, and melatonin. And then you have other alternative medicine, complementary medicine, you have psychological intervention and hypnotherapy. So that's the end of my slides. And in terms of the references, I think there is a lecture that was done last year by Dr. Scriba from Cape Town. It's on YouTube on the Gastro Foundation, When Reflux Not Reflux. It's a very nice summary for the reflux disease and management. Thank you. So if there are any questions. Don't know if Dr. Fredericks is still online. Yeah.
Okay, it looked like we lost Dr. Fredericks. Okay. Yeah, I think we lost him. He must have lost connectivity on his side. Professor Sachedi, could I call on you? Oh, Ernst is back. Okay, Fredericks is back. Dr. Fredericks, can you hear us? Okay. Okay. Okay, it looks like he's lost connectivity. No, he's still there. Dr. Fredericks, can you hear us? Okay. Okay.
Cheryl, it's Mashiko here.
Yes, hi there.
Hi, how are you?
All good, thanks. Okay, I know that Dr. Fredericks had some connectivity problems. I can see he's still online, but he might have problems. That's why he's not answering me.
Yeah, I must say, Patrick, I'm sorry. I couldn't actually listen because I had an ad hoc meeting with people walking into my office. So I actually didn't listen to most of your talk. I'm so sorry. But the whole time I was just thinking those three topics are probably quite a lot, but I think they are related, and I couldn't find that we could split them. So it is quite a lot to cover, but I thought you did well. But yeah, I couldn't really pay attention because these people walked into my office and I had to attend to them. But well done on that. I'm just trying to see if Ernst
Hi, Mashika and Patrick. I was able to hear like most of it. It was fairly comprehensive. So I think just for the fellows, it is one of those things that's referred to us often. It's common, and I think you have to, as a subspecialist, have a fairly in-depth idea of your reflux and your nuances around it as well. But yeah, I actually don't have too much to add. I think all those slides were very comprehensive. I don't know if anyone else has anything to say or add or ask, Patrick. Of Of course, if I can ask with regard to the pH studies, has anybody in South Africa have any experience with wireless pH studies? The Bravo capsule. Does anybody use it or has used it even occasionally?
So VG, I did a talk on GORD last year, and when I did some research, I couldn't find anybody who was using a Bravo, not even
Yeah.
in the private sector. So, I mean, so just from a theoretical perspective, the only advantage really of it is that you can actually monitor for longer, and so you have a better time frame within which to assess reflux. But I'm not aware that anyone is actually using it in the country.
And also, it's got no wires, obviously. So it's seems more comfortable, and I mean it will require scope. But yeah, I ain't sure how come it hasn't been marketed here in South Africa. I unable to even recall a stand or something at Sages or at a Congress where it's been actively marketed.
Yeah.
Maybe because there isn't a market here. It's expensive and will probably be under utilized.
Yeah.
I'm not sure.
I mean, even overseas, I'm not sure the take up of the Bravo was high in sort of everyday clinical practice. Maybe in units that do reflux as a research project, they are using it. It might have something to do with you, like you say, you need the scope to place it, and
Yeah, but I
maybe
mean,
it is expensive.
yeah,
It probably
yeah,
is expensive. Yeah.
I really don't think the scope is the issue. I mean, we scope people all the time with hardly any reflux. The other thing that I want to inquire about whether it's available or not are the PCABs. How widely available are they? Again, yeah, in South Africa. I mean, is it SAPRA approved? Is it available in on a script in a private?
Patrick, did you come across anything in terms of the PCABs availability locally?
No, unfortunately, I did not specifically look into that.
Yeah.
Okay, that's
Again,
fine.
I don't think they are, but dexlansoprazole is in private, and people are using it with
Yeah.
really good
Yes, yes.
reports and outcomes. PCABs, no, not that I'm aware of locally.
And
So,
maybe we can ask Patrick, what, where will you fit in, alganates in the whole algorithm of your reflux from a practical perspective?
So,
Basically, that's the one we see in the shops and on the adverts.
so from a practical point of view, probably I would those patients that have they don't have severe symptoms and they just need they have symptoms on and off, and you just need symptom relief from time to time. Probably those would be the ones I would recommend these agents. And from a guideline point of view as well, for those patients that have refractory GERD, you might consider adding those the agents to those patients.
And pregnancy as where although proton pump inhibitors are probably safe, but if you can avoid using it for in patients who are pregnant with mild reflux, I suppose that will be the other reasonable space for them. And he also spoke to the acid in patients with hiatus hernia who have an acid pocket. That's also a place where it is useful as add-on,
Yeah.
like in a treatment.
Even nocturnal breakthrough, so nocturnal
And
acid breakthrough, they can be quite useful as an add-on. Yeah. Yeah. It looks like Cheryl, Ernst is lost.
Yeah.
In Namibia, I'm not sure where he is. I'm not seeing any questions or comments on the chat. And I'm also seeing that it's 7:05. So fellows, does anybody else have any other questions? It sounds, Patrick, like you really did a fantastic job of a complex subject. And, you know, we see this a lot in practice, and sometimes really differentiating patients with true acid reflux versus the other groups is not necessarily that easy. And I think also people don't always have access to acid reflux testing so that one can confirm. And then I assume that you did cover that sometimes you do the test on PPI, and at other times it is quite important to make sure that you do the test off PPI, depending on the clinical situation. But well done. And I think if there's no other questions, it really leaves on me. Thank you, VG, for coming in there. Thanks for attending, and also for just picking up the discussion. So if there's nothing else, then I really want to thank Patrick for the effort that he put into preparing the slides, and also for Ernst hello, Ernst, can you hear us? I see you there now. It looks like there might be an issue with his connectivity. So thank you, everybody. Thanks, Cheryl, for all the work that you do behind the scenes. Thank you to the Gastro Foundation for the support on this platform and securing all of our sponsors to be able to offer this. And we will see you in 2 weeks' time on Monday. I don't know what the topic is, but we'll see you in 2 weeks' time on Monday at 6 p.m. Thank you so much, everybody. Have a good evening.
Thanks. Okay, cheers. Bye.
Cheers. Bye.